Hello everyone, my name is Jacob and we're going to be continuing our walkthrough on the treatment of pediatric hypertension. So earlier we learned how to accurately diagnose a patient with hypertension and we learned some non-pharmacological treatments. So right now I'm going to go over the pharmacological treatments and how the American Academy of Pediatrics has discussed how to treat these patients accurately. So the first thing that they mention is that the initiation of an ACE or an ARB should be initiated at the lowest possible dose and titrated up every 2 to 4 weeks, monitoring for the side effects or that their treatment of their blood pressure is being adequately controlled. Now you want to have them come in every 4 to 6 weeks until it's controlled, or if they don't accurately get it dealt with, so we can make sure their management is being done and their quality of life is not being impacted. Some signs and symptoms you want to be looking for are edema or renal problems. Serum creatinine is something you kind of want to monitor for. So the guidelines then move on and to say that whenever you initiate a second agent, if the blood pressure is not controlled on the first one, they put emphasis that they want the use of a diuretic simply because the mechanism of action of the ACE or the ARB could cause the child to have a retention of fluid. Now, because of this, because of the renal function, we want to make sure we diurese this fluid off, or it could be contributing as to why their hypertension is still not being controlled. So the addition of a diuretic such as chlorothalidone or hydrochlorothiazide is used. In this instance, you want to make sure to tell that patient about the side effects such as frequent urination so that they can adequately place that medication at a certain time as to not hinder their daily activities, especially while they're at school. Now, the guidelines also go on to say that a third agent could be added if those two agents still don't control it, but still they want you to look for underlying symptoms as this could be a problem. Now, if these three agents still are not enough, they want you to check for underlying symptoms, and after that, make sure you refer them to a specialist in which they can outweigh the risk benefits of adding more adult forms of hypertension control, such as aldosterone antagonists, such as spironolactone. Those have shown efficacy, but no case studies have gone in to prove that yet. However, the Academy of Pediatrics still recommend it. Now, the last line of treatment is that I'm going to discuss with you is if the patient comes into the emergency department because they have severe hypertension. In this state, the patient is 30 millimeters of mercury above the 95th percentile for their age, sex, weight, as per listed in their guideline via the charts. You want to make sure that if they come in this state that you are looking for an underlying symptom, because this is the most prevalent way that the hypertension can shoot this high in a pediatric patient. Now, because of this, we want to make sure to give IV esmolol or hydralazine or nicardipine just to drop it down to get them in a safe level, and then monitor them and make sure that we're taking care of the best way that we can. So just to recap, we want to initiate an ACE or an ARB first as a medication after non-pharm doesn't work. Then you want to move on into the diuretics and the calcium channel blockers, and then you want to refer to a specialist for a possible addition of a second one. If you guys have any questions,